Hello, everyone. Welcome back to Karan Academy. My name is Karan, and today we're going to be talking about hematological malignancies and myeloproliferative diseases as our third lecture in the hematology series. Now, I will preface this presentation by saying that this is going to be quite a bit of information. A lot of it's going to be new, and I know that blood cancers can be very overwhelming and hard to understand. So I've tried my absolute best to explain things in a way that hopefully makes a lot of sense. You would not be expected to know this level of detail for your exams. However, I still think it helps with understanding. And I think once you understand what's going on, as I've always said, everything just sounds easier. Here is a brief overview of the things we'll be covering. So we have leukemias, we have lymphomas, we have diseases of the erythrocytes, we have diseases of the platelets, and we'll go through all of that in a second. A good way I like to group our hematological malignancies would be, are they of a myeloid origin? Are they of a lymphoid origin? I think that's a good way. With myeloid cells, you obviously have your leukemias like AML, but then you also have your myeloproliferative diseases like essential thrombocytosis, Polycythaemia Rubra, Vera, as well as Myelodysplastic Syndrome. Don't worry if you don't know these terms, we go through all of them. And then with lymphoid cells, you have your lymphomas, your leukemias, or ALL, CLL, as well as multiple myeloma. To break down this huge list of conditions into some simple terms, what is going on? So what's actually pathological? Leukemias, we have too many white blood cells. Lymphomas, also too many white blood cells. With multiple myeloma, which is a cancer affecting plasma cells, we have too many B cells. Polycythemia rubra vera is a myeloproliferative condition of the RBCs. So we have a high RBC count. Essential thrombocytosis, high platelet count. And primary myelofibrosis is everything has kind of hit the fan and everything's gone wrong. Now, leukemias versus lymphomas is a very interesting area of hematology. It's one that's quite commonly debated, and it's one that's hard to understand. Both are cancers of white blood cells. What you need to know is where they start. So when I say the person has a leukemia, I mean that this person has a hematological malignancy that started in the bone marrow, while lymphomas are cancers that start in the lymph node. Now, from a clinical perspective, what's very tricky is often distinguishing between them clinically in someone with quite a progressive disease. Now, why might this be the case? Well, as cancers metastasize and move around in the body, and obviously these are hematological cancers and they're going to be spreading quite extensively. You can have leukemias that started in the bone marrow and have eventually found their way into lymph nodes. Likewise, you can have lymphomas that started in the lymph node but now have spilled out of the lymph nodes and infiltrated the bone marrow. Do you see where I'm kind of going with this point? When you look at a lymph node, you will just see cancerous cells. And it's often hard to tell whether this T cell or B cell originated from the bone marrow and is therefore a leukemia, or was it intrinsically a lymphoma, right? And we'll spend a bit of this presentation talking about that, but let's start with both of them independently and then talk about the line between them. So as I mentioned, the thing with leukemias is these are cancers of the bone marrow, and they can spread elsewhere. You need to know the difference between myeloproliferative and myelodysplastic disorders. So myeloproliferative, as the name suggests, are you have proliferation or extra proliferation of cells, and therefore the marrow is making too much. So things like Polycythemia rubra vera, which is the RBC one, essential thrombocytosis, which is the platelet one, you just have too much. Versus myelodysplastic, which means we have an issue with the bone marrow itself, and that's commonly with fibrosis. And here is, I guess, a representation of what we'll be talking about. When you talk about lymphomas, the two questions I want you to always ask, firstly, are what the type of cell is in terms of its maturity and what the type of cell is in terms of origin. So you have faulty cells. Are these mature cells or are these immature cells or blasts? And whatever cell we're talking about, is it of a lymphoid or a myeloid origin? So let's talk about how we can make that distinction. And here is kind of a spectrum of disease according to age. So ALL presents usually in kids, CML around people aged 40, AML a bit older, and CLL is usually a disorder affecting elderly individuals, and it's one of those ones that's chronic, it's slow growing, and people often die with it instead of from it. So let's talk about the difference between acute and chronic leukemias. So when I say acute leukemia, I mean that the faulty cell is of a blast cell origin. As you can imagine, blast cells are very metabolically active. They're rapidly reproducing, replicating cells, and therefore acute leukemias or any leukemia of a blast cell would present more rapidly, would present with more severe symptoms in a shorter duration than chronic leukemias. I hope that makes sense, right? Versus if you had a leukemia of a mature cell that is not going to be dividing as rapidly, that's not going to be as metabolically active, it would present as a chronic leukemia instead. So what happens? So I guess when you look at the symptoms of the patient, you need to ask yourself, well, what's going on? Now, obviously, I've said that you have excessive levels of WBCs or white blood cells because that's what the leukemia is. But then why do we get all this other stuff? Well, as you start producing such high levels of WBCs, you tend to crowd the bone marrow to the point where it can't make anything else. So you actually may have eventual failure of the bone marrow. And this is often seen in acute phases. Because of this, the bone marrow is unable to do or produce the rest of the stuff it usually does. So can't produce RBCs as much, which is why you get the shortness of breath on exertion as well as fatigue. And clinically, they might have a pallor, conjunctival pallor of the palmar creases, and so on. Increased infections. Now, well, why do we get increased infections? Didn't we just say that we're producing too many white blood cells? Shouldn't that be more protective? Well, good thought. But then again, remember that the white cells we are producing are dysfunctional cells. So although we have way more than what we should need, these cells are not even functional. So we still have a high risk of infections. Increased bleeding and bruising because we aren't producing platelets as effectively. And then you can also have lymphadenopathy and hepatosplenomegaly because the lymph nodes, the liver, and the spleen are all sites where these WBCs can deposit once they've left and leaked out of the bone marrow. Let's start off with our acute myeloid leukemia. So as the name suggests, it's acute, which means it's a leukemia of blast cells. Myeloid meaning it's leukemia of a myeloid origin, right? That's what you need to know. You need to know that when you look at a peripheral blood smear, you will see tons of blasts. Now, again, why do we have blasts in the blood? Aren't the blasts meant to be in the bone marrow? And you'd be absolutely right. In a normal patient, a normal individual, you should not see blasts in the peripheral blood because they are meant to be purely contained in the bone marrow where blasts do what they are meant to do, which is divide. However, with our acute myeloid leukemia, we have such high levels of blast cells in the bone marrow, it starts leaking out into the peripheral blood, which is why we see these blast cells in the peripheral blood smear. Now, what's interesting to know is that if you just look at a microscopic picture, and if you see blast cells, well, you can't really tell whether they are lymphoid in origin or myeloid in origin, which is why it's sometimes hard to distinguish between AML and ALL. This is where flow cytometry comes in, where it is able to look at certain specific markers on the blast cell, and that can help distinguish myeloid progenitor blasts from lymphoid progenitor blasts, right? As I mentioned, the bone marrow is going to be filled with blasts and the threshold is about 20%. How will this present? It presents with everything we just talked about. So anemia, thrombocytopenia, leukopenia, gum hypertrophy. Sorry, leukopenia is just low levels of WBCs. And you might be a bit confused because we just said that we have high levels of white cells, right? You need to know that when we look at or perform an FBE, the white cell count refers to mature WBCs. As you can see, we're going to have tons of cells, but they're going to be immature blast cells. So effectively, low levels of mature blood cells. Gum hypertrophy or hyperplasia of the gums is quite commonly seen it's seen in about 5% of cases, not as common. And it's considered to be So there are two things that they think might cause it. First is the infiltration of these white blood cells into the gums themselves. And secondly, they think it could be an infective exacerbation of pre-existing periodontal disease, but that's not relevant. I just thought it's a bit interesting. Hepatosplenomegaly, again, because those parts are where your WBCs would infiltrate. And then you can also have lymphadenopathy if there's lymphatic involvement. The buzzword for this is these things called Auer rods, which are cytoplasmic inclusions, which look like this and are specific to AML. We'd want to treat this super aggressively with chemotherapy, and they often have a good response. Now, acute lymphoid leukemia, very, very similar. As I said, it's going to be tons of blasts. These blasts are going to be lymphoid in origin. You're going to have more than 20% of the bone marrow being blasts, and this is most commonly seen in kids. And it presents with pretty much the exact same set of symptoms. Plus, ALL is notorious for having the triple B combo. So it has involvement of the brain, the balls, and the bones. So you can present with meningism. And this is all based on where these blast cells infiltrate into. So if they infiltrate into the brain, you can have meningism. With testicular involvement, you can have painful swellings. And with bone involvement, you can have bony tenderness. Again, hit them super aggressively with chemotherapy, and they have relatively good prognosis. Now, talking about the distinction between AML and ALL, morphologically, you would see the cytoplasmic granules or Auer rods with AML versus ALL, which would have a higher nuclear to cytoplasmic ratio. AML more common in adults, ALL in kids. Now, flow cytometry is where I talked about identifying those unique markers that are present on the cell surfaces, right? This is where I tell you that CD34 is specific to blasts, and therefore both of them would be CD34 positive. But I'll just preface this by saying these names and numbers are not relevant, and you would not be asked about CD34 positivity. But if you keep seeing this on lecture slides or tutorials, and no one really explains what these mean, so I just thought I'd explain this. So CD20 is something that's found. So CD20 is something that's found on all B cells, right? CD34 is something that's found on all blast cells. Don't remember these numbers, just for this bit. Both of them would be CD34 positive because both of them are blasts. You then have myeloperoxidase or MPO that's specific to myeloid cells, and then TDT that's specific to lymphoid cells. So therefore, AML would be CD34 positive, MPO positive, TDT negative, while ALL would be CD34 positive, TDT positive, MPO negative. I hope that kind of makes sense. In terms of treatment, you would usually start them aggressively with chemotherapy, and then later you can also consider other interventions like bone marrow transplants if they do not have the best response or if they are young and suitable for bone marrow transplant. Now talking about chronic myeloid leukemia. So as I said, this is a myeloid origin chronic issue. So you would have mature cells, right? And this is a slower cancer. And I hope at this point you understand why it's going to be a slower cancer, because our mature cells are not rapidly dividing. You very commonly see a translocation in the 922 translocation, and this is called the Philadelphia chromosome, and it has a role in the tyrosine kinase enzyme. It has 3 stages. It has an indolent stage, kind of where it's in the background, doesn't really do much in that chronic stage, low level of replication. Then for some reason, it can pick up quite rapidly, and you can actually have a transformation into an acute stage. So you can actually go from CML to AML. And then you can have a blast crisis where, again, you've infiltrated the bone marrow with so many blasts that your bone marrow starts failing. As you can see here, you will also see tons of lymphocytes. And these would be lymphocytes and not blasts, because again, this is chronic. How would this present? Exactly how many of the others would. So anemia, thrombocytopenia, and leukopenia, and we treat them with tyrosine kinase inhibitors like imatinib, and they have an excellent response in most cases. CLL or chronic lymphoid. Sorry, wait, oops. Sorry about that. I think I incorrectly said that these would be lymphocytes. No, these would be either neutrophils, as you can see with the segments, or some myeloid origin cells, not lymphocytes. My bad, sorry. With CML, this is where you would see tons of lymphocytes. And as you can imagine, this is going to be a very slow growing tumor. Very rarely does it have an accelerated or a blast stage. It's one of those things where you're more likely to die with than from, and it's usually picked up incidentally. You often also see smudge cells, and this is basically because the cells kind of lies and appear to be smudged. And you basically have a very wait and watch approach to managing CLL. You would only treat them if they are symptomatic and if they have a relatively long life expectancy. So if someone is expected to live for 2 or 3 more years, it's very unlikely that you treat them. So again, here's a good summary table that you can go through in your own time. I will not be expanding on this much further, but we've already talked about all the important bits. Now let's talk about lymphomas. So buckle up, because I personally think lymphomas are a bit harder to understand, but I feel that the big brain knowledge realization with lymphomas is much more, and it feels nice to understand what's going on, because lymphomas, in my opinion, are quite confusing. So let's set up some ground rules. Lymphomas start in lymphatic tissue. Number 1, leukemia starts in the bone marrow. I know I've said this before, but I'm stressing on this again. You can, again, have one spreading to the other, and this can make them hard to differentiate between the two. With the lymph node, we have a natural progression of various white cells entering the lymph node, undergoing maturation, proliferation, and then churning out some more mature cells like memory B cells or plasma cells. And with lymphomas, we basically have an issue somewhere along that progressive course. And over the next 5 to 10 minutes, you are going to think, oh my God, this makes so much more sense. Why didn't I think of this way? And because that's what happens to me every time I read this. I also realize I'm probably overly enthusiastic about lymphomas. Okay, so let's draw out what's going on here. So these are the different steps. And at every step, you can have something going wrong. You can have the naive B cell that just has an issue with it before it even enters the lymph node. Okay, that's just a poor effort. It hasn't done much and it's already suffering. You can have a naive B cell that's just entered the lymph node that goes wrong. The naive B cell then replicates rapidly, and during that replication process, something can go wrong again. The bad cells that were meant to die from this replicative process, as with any replication, you will have some cells that are just shitty cells, and you want to usually get rid of them. These cells are usually meant to die, but if they don't, again, that can lead to problems. Finally, you have 2 classes of cells that are churned out. These are mature cells, so plasma cells and memory B cells, and you can have issues with both of them. Now, instead of calling just a cancer of a lymphoma of naive B cells, or cancer of plasma cells, or cancer of memory B cells, we just chose to give them just names that just baffle me, and it makes every medical student's life incredibly hard, but it should not be. So let's call them what they are called in hematological terms. So a naive B cell, if it undergoes a lymphomic transformation before it enters the lymph cell, that's going to be called a precursor B cell leukemia. Again, technically, it's still within the spectrum of lymphomas, but because it hasn't originated within the lymph node itself, we still call it a leukemia. Does that make sense? You then have the naive B cell that's just entered the lymph node, and that's going to be called a mantle cell lymphoma. It's called a mantle cell because it is formed around, or it is formed in the periphery or the mantle zone. Then as the cells start rapidly multiplying and forming huge colonies, you can have 2 types of lymphomas: diffuse large B cell and Burkitt lymphomas. The cells that are meant to go off and die in the peripheries enter the follicles, and this would be called a follicular lymphoma. And then the plasma cells, if they undergo a change, would be called multiple myeloma. And then the memory B cells would be called CLL. Now, why is it called chronic lymphoid leukemia? Now you'd be thinking, oh, Karan, you just said that, well, the memory B cells are produced and they leave the lymph node. So if they then undergo a change, technically that change is still in the blood, which is why it's called CLL. I hope that makes sense. So the first and the sixth are both leukemias, but they fall under the spectrum of lymphomas. That's confusing to me, and I never really got it until like last month. So now, instead of memorizing the prognosis and the efficacy of each one of these, let's just go back to our simple, dumb brain selves and break things down and make it super, super easy. Some basic principles that I've already gone through. Cells are either going to be rapidly dividing or slowly dividing, right? And that's really important to understand how they're going to respond to chemotherapy, which is going to be the bulk of our therapy. And it's also good to understand kind of prognosis and cure rates and everything. Everything just will start making sense so soon. Let's take an example. Burkitt's and DLBCL, or diffuse large B-cell lymphoma, are both lymphomas of rapidly dividing tissue, because remember, they are formed in this rapidly dividing stage. As you know, chemotherapy is great at targeting cells that are rapidly dividing. And this is great because our chemotherapy is going to kill these rapidly dividing cells. And although you have a high risk of death because this is so rapidly dividing, you have a high chance of cure, because at almost any point, if you just take a snapshot in time, a very high, up to 80 to 90% of all these lymphoma cells are going to be in the replicative phase, which is going to be hit by chemotherapy. Now, let's take the example of a slower growing lymphoma, like follicular lymphoma. As I said, because this arises from shitty cells that were meant to go and die, follicular lymphomas tend to be composed of more mature cells. And as we know, mature cells don't divide rapidly. Because they don't divide rapidly, it's kind of nice because they won't be very, very aggressive in how they present. But at the same time, chemotherapy is not going to be as effective, right? Because comparing this to something like Burkitt's lymphoma, a very small percentage of all the cells are going to be in an actively replicating phase, 10, 15, some arbitrary number that's going to be a very small fraction of the total cell count. And so even if you kill those 15% of cells that are replicating at that point in time, you are very unlikely to get everything. And therefore, although this won't kill us, it's also very hard to cure these slower growing lymphomas. At this point, I hope you're like, oh, well, this is so good. Because now, if you were to ask me about, I don't know, a certain lymphoma, it's relatively easy to explain, right? So now you know DLBCL, Burkitt's lymphoma, have a bad prognosis if you don't treat them. This will kill you, but if you treat them, they have very good response to chemotherapy with a high cure rate. This is follicular, mantle cell, CLL, all going to be slow growing, lesser risk of killing you, but lesser chance of you curing the disease as well. So I guess it's just to pick your lymphoma and pick your risk. Now you would have heard of Hodgkin's and non-Hodgkin's lymphoma, and this just complicates things ever so further. Basically, what happened was some dude looked under a microscope ages ago and saw some owl-shaped bodies, and these are called Reed-Sternberg cells now, and called any lymphoma that has these Reed-Sternberg cells Hodgkin's, named after himself, quite humbly. And so now we had Hodgkin's and then non-Hodgkin's. So if you have Reed-Sternberg cells, that's Hodgkin's. If you don't, everything else is non-Hodgkin's. So let's talk about Hodgkin's lymphoma. As I said, Reed-Sternberg cell positivity. They're typically made up of B cells and present with kind of a dual phase epidemiological presentation. So in the third and the sixth decade of life, associated with infections like EBV. Two important, unique presentations. So the first one, so we have Pell-Epstein fevers and alcohol-induced pain at the lymph nodes. Now, these are both quite interesting presentations because they're quite specific to Hodgkin's lymphoma. So a Pell-Epstein fever is a fever that is very high grade, that keeps rising and keeps falling every week or so. So what happens is you have a fever, all of a sudden it stays high for a week, and then slowly after falls back to normal, and then you cycle through that. Very interesting. And then you also have alcohol-induced pain, especially in the cervical lymph nodes. You also have two broad types. So you either have classical Hodgkin's or lymphocyte predominant Hodgkin's. The classical Hodgkin has 4 subtypes. I would recommend you know this for your pathology exams. So nodular sclerosing, which presents with a rose flower pattern, lymphocyte rich, lymphocyte deplete, and mixed cellularity. So talking about these, nodular sclerosing is the most common. When we treat Hodgkin's lymphoma, the more the lymphocytes, the better, is how I think about it. So lymphocyte rich is going to have an excellent prognosis. Lymphocyte deplete is going to have the worst prognosis, and mixed cellularity is going to be somewhere in between. We use a PET scan, and that is really good at picking up these lymphomas, because these lymphomas have very high metabolic demands, and you can actually radioisotopically tag glucose, and then you can see which parts or which lymph nodes are taking up high levels of glucose, and that will be pathological. You then classify these lymphomas based on the Ann Arbor system of classification. So stage 1 is if you have a single node. Stage 2, multiple lesions on the same side of the diaphragm. Stage 3, lesions on both sides. And then stage 4 is disseminated disease. The treatment is a chemotherapy combination of A, B, VD. So you have adriamycin, also called doxorubicin, bleomycin, vinblastine, and dacarbazine. So these 4 drugs, up to you if you want to memorize them. I don't see this being tested, but again, if you want to flex on your hematology consultant, a good way to do that. Now, non-Hodgkin's lymphomas are all the other ones, and we've talked a bit about a lot. We've actually talked about most of them already. They're associated with EBV, HIV, and you can also have gastric lymphomas and maltomas because of H. pylori infections. So these can be follicular, marginal, diffuse large B cell, mantle cell, and Burkitt's. Just to reiterate, I'll quickly go over where each one of these lymphomas arises from. Follicular arises from the cells that were meant to die that don't. And this is obviously going to be in the follicles. Marginal is going to be a naive B cell just as it enters the follicle, found in the sorry, my bad. That's going to be a mantle cell. Marginal are going to be around the margins of the lymph nodes. Diffuse large B cell and Burkitt's lymphoma are going to be those lymphomas of the rapidly dividing B cells. Here are some more buzzwords, important to know. So follicular is the most common low-grade lymphoma. Marginal has associations with autoimmune diseases. Diffuse large B cell is the most common lymphoma, and it's the one I saw most commonly during my hematology rotation. Mantle cells are going to be spreading very rapidly, and Burkitt's is most commonly seen in kids with what's known as a starry sky appearance on a lymph node biopsy. What you also need to know is that, as we talked about with our leukemias, we would perform something called flow cytometry to identify cells that are CD20 positive, because we have specific monoclonal antibody therapies that can target these CD20 positive cells, and that's a medication called rituximab. So it's really good to know. I personally, and a lot of people don't like the Hodgkin's, non-Hodgkin's classification system because it doesn't make much sense. It doesn't guide the aggressiveness or how you treat them. So instead, here is kind of a system that I was taught, and I personally find it very, very useful. So split them into low-grade, high-grade, and very high-grade lymphomas. So low-grade, as I said, they're going to be slow-growing of mature origin. The important ones you should know are follicular, mantle cell, and marginal, and CLL2. You usually are not able to cure them, but that's kind of okay because they are not very likely to kill you either. You don't treat them usually unless you're symptomatic. And there are 2 exceptions to this. If you have stage 1 or stage 2 follicular lymphoma, you would treat that with radiotherapy. And if you have CLL, with a rapid increase in the white cell count. So as I said, CLL, the leukemia you die with, not from. However, if suddenly, and obviously we'll be doing regular FBAs on these patients, If you see a doubling of the white cell count in a short period of time, you should commence treatment. With high-grade lymphomas, always treat them. And the aggressiveness depends on the stage. So stage 1 and 2, about 3 rounds of chemo and radiotherapy. Stage 3 and 4, obviously you want to go something a bit more aggressive, so 6 rounds. And the main one you should know is a diffuse large B-cell lymphoma. Now, with very high grades, you will die if you don't treat them, and death can happen within days to weeks. You have this thing called tumor lysis syndrome. That's a very high risk with these patients. What tumor lysis syndrome basically is as you start chemotherapy, you're obviously going to start killing cells. And as you kill cells, you're going to have dead cells floating around in your blood, releasing into the blood all their contents, including electrolytes. If you have too much of this going on, you can end up with something called tumor lysis syndrome. That's not good. And the exact staging with these very high-grade lymphomas doesn't really matter because we're going to hit them with the maximum doses of chemotherapy that we can. So we give them high-dose combined chemotherapy. And the important one you should know is a Burkitt's lymphoma. As I said, they're going to be very large cells and have a starry sky appearance. Then we have Hodgkin's lymphoma that I just like to put here. Reed-Sternberg cells, ABVD therapy, already talked about. And you would have already the symptoms that we've discussed quite thoroughly. So again, on flow cytometry, I've just compared the low-grade lymphomas. So flow cytometry, this is where I tell you that CD45 refers to lymphocytes, CD1920 refers to B cells. So all of them would be CD45 and CD1920 positive because all of them are B cell lymphocytes, right? The main differences are with CD5 and CD23. I don't know the exact functions of these two markers, but as you can see, they have different combinations with each one of them. And the two important translocations are 1114 with mantle cell and 1418 with follicular. I just put this in because we talked about cancer markers earlier. So here's a list of most cancer markers that you will see across your oncology teaching. I won't go through each one of these, but here's just a good summary. If you see them, this is what they're referring to, or the cancers we are worried about with each one of them. Now let's talk about multiple myeloma. So multiple myeloma, as I said before, is a cancer of mature plasma cells. Because again, these are going to be mature, slow dividing cells. You already know that they're going to have a poor response to treatment because you guys just are so good at understanding these things. Now, what do plasma cells do? Well, plasma cells produce antibodies, right? And if you have a particular line of plasma cells that's just gone off the rails, you would have one particular type of antibody being produced in high numbers. And the complex term to explain that is just a monoclonal gammopathy. Clinical features you need to know when we talk about multiple myeloma is the CRABS acronym. So issues with calcium, so hypercalcemia, and as you know, that's stones, groans, bones, and moans. Renal failure, because you have high levels of calcium being excreted, as well as high levels of immunoglobulins being filtered through the renal tubules, and this can damage them. You would have anemia, because over time you can have infiltration in your bone marrow, causing bone marrow failure. Bony lesions, partly because of the osteolytic process that's ongoing. As you can see here, you can see a pepper pot skull with extensive dots throughout the cranium. And splenomegaly, because your immunoglobulins are going to be accumulating in the spleen. In terms of specific buzzwords, a lot of these monoclonal gammopathies are going to present with high levels of protein being excreted in the urine, and this would be called the Benz-Joyce protein. You can also have rouleau formation, which is the stacked appearance of RBCs, and that's because of high levels of plasma proteins. And then you would also have the M spike on plasma electrophoresis, indicating that you have high levels of one particular gamma chain being produced. And this is what the M spike looks like. Next, we have Polycythaemia rubra vera. Now, this is a myeloproliferative disorder because resulting in too many RBCs. Most of them are associated 95% with a mutation in the JAK2 gene. In terms of signs and symptoms, you can have a high risk of bleeding, DVTs and PEs because you are now hypercoagulable. You can have burning pain in the hands and feet, and this is called erythromic malacia. You can have pruritus after a hot shower, and this is a common buzzword for PRV, and gout, because you are now producing a lot of RBCs. High production would mean high destruction. With high destruction, we are worried about gout. Complications, again, you will be prone to forming clots, and that's going to put you at a high risk of strokes and ischemic heart disease. This will be diagnosed by a high hemoglobin count, a high hematocrit, and a high red cell count. In terms of management, we don't really worry a whole bunch. We can start them on a phlebotomy to release blood regularly, and this would help lower the red cell count. You can give them prophylactic aspirin for their clotting risk and allopurinol for gout. Essential thrombocytosis, very, very similar process, except now you just have too many platelets. Again, 50% associated with the JAK2 mutation, and headaches, thrombosis, again, because of hypercoagulable state. And you also carry risk of spontaneous abortions in pregnancy. Next, we have primary myelofibrosis. Now, instead of producing too many cells, we are going to have a bit of a different picture. So now, instead of producing too many cells, you're producing abnormal clones of these hematopoietic stem cells. These clones would produce high levels of cytokines, which is pathological because, as you know, cytokines equals inflammation, and you don't want that. Some of the cytokines produced include things like fibroblast growth factor, and this is going to lead to, as you can imagine, the high levels of fibroblasts, which would be laying down fibrin within the bone marrow. And you don't want this because this is now just going to lead to fibrosis. So as the name suggests, primary myelo or marrow fibrosis. So now you have fibrosis in the bone marrow because you've produced cytokines like fibroblast growth factor. Again, very commonly associated with JAK2. And now you're going to have bone marrow failure because of this extensive fibrosis. You can also see something called teardrop cells on the blood film, as you can see here. And the memory trick I have for that is, well, if you just think about a highly fibrosed bone marrow, and if you think of RBCs trying to kind of squeeze through the tight fibrotic tissue, that's going to lead to this teardrop appearance. And you would have a dry bone marrow aspect, well, because you now have no bone marrow, you just have extensive fibrosis. You would also have have high levels of white cells and platelets at the time of presentation, but this will eventually drop as the tissue starts undergoing fibrosis. And lastly, we have Myelodysplastic Syndrome, which is, instead of having no maturation, you have ineffective maturation. So you have cells still being produced, but the cells are just horrible. So you can have a microcytic anemia, hyposegmented neutrophils, giant hypogranular platelets. So you're still producing things, but they just don't look like what they should be, and they just do a really bad job. And the treatment for most of these would be supportive. Thank you all for coming. I know that was a bit of a big and longer presentation. I hope that all made sense. If it didn't, please feel free to get in touch. I'm always happy to answer questions. And as always, please look after yourself and please look after your loved ones.